Good afternoon, everyone. Thank you for joining us this afternoon for today's COVID-19 update for primary care. So my name is Charles Broadfoot and I'm one of the Professional Development Officers with the PHN. And I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands in which we are meeting on this afternoon, and also pay my respects to elders past, present and emerging. So today's session is being recorded, and the recording and the slides will become available in our PHN Education Library shortly this afternoon. To access this, just head to our website, thepHN.com.au, and click on the Education tab. There also will be a short evaluation survey that will automatically pop up when the webinar ends. If you could just take a minute to fill this out before you log off, we really appreciate your feedback. So you can type in questions for our presenters and our speakers today. So you'll see in your control panel the chat box, so please type them in throughout the presentation. We have allocated time for Q&A after the main presentation. So I'd now like to introduce today's facilitator, Kimberley Booth. Kim is the COVID-19 response lead with Hunter New England Central Coast PHN. So I'll hand over to you. Thanks very much, Kim.
Thanks, Charles. Hi, everybody. I also would like to acknowledge the traditional owners of the lands that we're meeting on today and pay my respects to elders past, present and emerging. So my role this morning or this afternoon is to introduce our amazing panel of presenters and Q&A facilitators. So our presenter is Dr. Kat Taylor, who is the Director of the Public Health Unit for Central Coast Local Health District. And I've also got joining us for the question and answer session is Lynne Bickerstaff, who is the District Director of Nursing and Midwifery for Central Coast Local Health District, and Liz Grist, who is the Executive Director for Clinical Services, Nursing and Midwifery, and also the COVID-19 Vaccination Coordinator for Hunter New England Local Health District, will be joining the Q&A session after Kat's presentation. So we're very lucky that Kat's dedicated some time for us this afternoon, given the schedule that you've got at the moment. Kat, we very much appreciate it. I'll hand over to you.
Thanks, Kim, for that warm introduction, and thank you too to all of the participants out there for your time, noting that we're all quite under the pump at the moment. So I'll just, hopefully this slide works.
Yep, that looks great.
Just confirm that that's showing? Great.
Yep. Okay.
So yes, thank you for the opportunity, and we did think it was timely for a brief update to the primary care sector, noting how quickly things move in a COVID pandemic and particularly a Delta outbreak. So you've all obviously seen the headlines from yesterday. So COVID is a lot closer to home now. We have had cases on the coast for some time now, but also our friends in Hunter, New England are also being affected now. And fortunately, the lockdown restrictions have been expanded to there, which seems a very sensible decision in the current climate. Just a quick sort of overview of the epidemiology to date, and you can see that unfortunately the number of cases in New South Wales continues to be rising and starting to approach actually the peak of that so-called first wave that we had in March 2020. Although the key difference here, you can see overseas acquired cases are outlined in light blue and locally acquired in dark blue. And unfortunately, you can see here that the curve is predominantly dark blue this time around. So we're talking about locally acquired cases, which has sort of a very different effect on the detection and ongoing epidemiology of the outbreak. And unfortunately, as one of my colleagues, Dr. Akhtar Hussain, says, we're still on the left-hand side of the curve. So lockdown restrictions have been extended to the Hunter, and at the end of last week you would have heard that the lockdown has been extended across Greater Sydney, including the Central Coast, for at least another 4 weeks, so at this stage till the 28th of August. So very concerning, and you would have seen some of my earlier presentations speaking about the Delta variant and how it is, in the order of 2 to 3 times as infectious as the ancestral strain, and so that really is causing some difficulties with both case numbers and contact tracing. Just a few key figures about the Delta outbreak. As you're aware, the numbers have been sort of in the 200s, but we're now actually approaching 300 new cases per day. There is really a challenge, and the Public Health Network is surged maximally to be interviewing cases and performing contact tracing. And tragically, you know, although this has largely been an outbreak of younger people, we have seen 75 deaths. Those have predominantly occurred in the older age groups, but you would have heard those very devastating headlines of, you know, people in their 20s and 30s passing away, and also requiring intensive care support. The key outbreak activity remains in sort of Western Sydney, Southwest Sydney, and the Sydney Local Health District, but noting that, you know, it's no longer a Fairfield restricted problem. You know, it's something that has rapidly expanded, and most LHDs are being affected by cases, including in the regions, and now, as you're aware, Hunter New England. And so, you know, it does continue to expand in spread, with growing numbers unlinked and also in the community whilst infectious, which is what is making this virus so difficult to contain. This is just a little figure giving a bit of a visual demonstration of the outbreak broken down by sort of Southwest Sydney, Western Sydney, and the rest of the metropolitan local health districts. And this just gives a bit of a visual picture for what we're dealing with, I suppose. So you'll hear, you know, reports of the numbers of cases that have been in isolation or in the green for the entirety of their infectious period. The amber or medium risk denotes people that have been infectious in the community for a day, and high risk, the red, is people that have been infectious in the community for more than one day. And so you can see that, in fact, in Southwest Sydney and Western Sydney, predominantly now we're seeing, you know, household contacts, and with the enhanced lockdowns, we are seeing not as much activity in the community whilst infectious. But concerningly, in the rest of the metropolitan local health districts, we're seeing, you know, sort of half of the cases being potentially infectious whilst in community, and probably a higher proportion of those being unlinked. And so certainly we've seen, you know, our experience has been with locally acquired cases that if people don't have any known epidemiological connections to a cluster, you know, there's often more of a delay to seeking testing because the symptoms of COVID-19 can be quite mild or even asymptomatic. So it is really causing an issue in terms of being able to contain this outbreak, particularly, you know, in the so-called unaffected LHDs. But I guess, you know, we are all affected now. So just to give a brief overview of the epidemiology of the most recent cases, with thanks to my colleagues at Hunter New England for some of this data as well. So obviously a rapidly evolving situation. There are two clusters currently under investigation in Hunter New England. One is that cluster associated with a case from Western Sydney who came up to the Hunter region. This person had been infectious since sort of the 28th, and there was this now quite infamous beach party. Although that may have been a bit of a red herring, it seems as though you know, household transmission has been responsible sort of initially for some of those secondary infections. Associated with that cluster, there have been 19 close contacts, of whom 6 have developed infection so far. And they, as I said, are all household contacts of the cases. There is a second cluster which has just transpired overnight. So a Central Coast resident who was positive on the 2nd of August, and then subsequently his whole household was discovered to be positive, of whom 3 of his household members attended face-to-face schooling in Morisset High School and Lake Munmora High School. Now, one of the children who attended the Morisset High School did catch a small private bus route to that high school. And so unfortunately, there have been 7 close contacts identified in association with that bus, of whom 1 has developed a secondary infection. Just focusing on the Central Coast cases, we've had 15 active cases. We currently have 15 active cases, though noting that the majority of these cases are not currently on the coast because most have been moved down to the special health accommodation in Sydney. So these ones highlighted in the green are some earlier cases who have now actually been released from isolation, both associated with Sydney. So, you know, as we saw in the earlier stages of the outbreak, I guess, you know, we could rely on epidemiological risk of having been in Greater Sydney or having been at a known exposure site, but noting that the exposure sites are now sort of in the hundreds and thousands, it's much less easy to kind of tease out, and this is the reality of community transmission, unfortunately. So sort of since the 22nd of July, we've had a couple of cases that have been linked with construction sites in Sydney. But concerningly, most recently, so this week, we were notified of an unlinked case on Wednesday from a test that was done a couple of days before that. And this person professes not to have had any known exposures or connections with Sydney or any other identifiable links that we can glean. And also, unfortunately, as I mentioned, their large household of 7 other family members also all tested positive once we'd identified that this person was a case. So, so that's a family of 8 people who are being relocated to this special health accommodation today. And as I mentioned earlier, there has been secondary transmission from one of those cases to the Morisset bus driver. So this has also resulted in some exposure sites of interest. Concerningly, the most recent cases did have some community exposures whilst infectious. You would have heard about the 2 schools that have been closed for contact tracing and cleaning. The one in the Central Coast area is the Lake Munmorah Public School, and the Public Health Unit's been working through calling the close contacts, and New South Wales Health has contacted the casual contacts. There are also a couple of shopping centres, the Lake Munmorah Shopping Centre and the Lake Haven Shopping Centre. These have been identified as casual sites of contact. So really just heightened awareness in that northern area of the Central Coast. Which brings us into sewage surveillance. I never thought that I'd be so fascinated by sewage, but it actually has turned out to be a very informative and useful program of surveillance. So with quite good sensitivity as well. So our understanding of the sensitivity of the sewage detections is that, you know, it can be anywhere from kind of 1 in 25,000 up to potentially even, you know, 1 in a couple of 100,000. But we've only got relatively small sewage catchments on the coast. There are currently 8 sewage surveillance sites across the coast, and they actually cover the entire sewered population of the coast. But notably, only 2/3 of our population are connected to a sewer main. So we can't completely hang our hat on it, but of interest, sort of over the past week, we've been getting unexplained detections in the Tukley area, noting that this was where our initial sort of household of 5 people resided, but they had been moved down to Sydney, so weren't really responsible for these ongoing detections. Fortunately, we've been following up about 50 close contacts in association with the person that was in the community whilst infectious, and most of those people are being released this weekend, and we haven't had any detections in any of those identified close contacts. So it's a bit of a mystery what's been happening in Tukley, but I think, you know, heightened vigilance is required still. The sewage detection did increase quantitatively, progressively from the 27th up until the 31st. And since then it has actually decreased. So we do have a bit of a quantitation on the number of viral copies that are tested in sewage. So it appears to be fizzling out, but as I said, we don't have a satisfactory explanation why it was there all of last week. And then concerningly, we have had some other sewage detections pop up in Charm Haven. You can see the suburbs that are included in that catchment there, and also in Woy Woy. So these were detections taken from earlier this week. Resampling has been undertaken. They were low-level detections, so, you know, if they are a one-off, it is possibly explainable by someone that's just visited the area, or, you know, a case that may still be shedding but not infectious. But we don't have a good explanation for these detections, and so we've really been trying to promote enhanced testing really across the entire Central Coast. As I said, we're in an environment of community transmission in Sydney, and, you know, we're so interconnected in both the Central Coast and Hunter New England regions with Sydney. I'm sure there's been lots of discussions amongst your colleagues and your groups about what does this mean for general practice, and I certainly am not professing to be an infectious infection control expert, but there have been some sort of high-level discussions in terms of what the advice for GPs and medical centres is, noting that, you know, GPs and medical centres are considered essential services, and certainly our colleagues in Sydney have really been feeling the pain, as it were, of many cases actually presenting to medical centres because, you know, seeking medical care is a reason that people who are meant to be isolating for COVID can leave their house. So obviously, you know, some further communications needed in terms of, you know, trying to encourage these people towards telehealth and sort of a bit of a heads up to reception to be able to triage them appropriately. But this is a matrix that's been developed by the Clinical Excellence Commission, just summarising the guidance for GPs and medical centres. We are also sort of coming out of winter, beautiful sunny day today, but, you know, we have seen seasonal acute respiratory infections increasing in the community as well. And so I suppose the key thing that I wanted to draw your attention to within this matrix is the recommendation that eye protection should be worn as part of adequate PPE. And so the current thinking is that you know, a gown is ideal as part of full PPE, but really the protection against this virus comes from protection worn from the neck up. And so it really is about having a mask and eye protection in terms of, you know, really trying to minimise that risk. Currently, New South Wales Health is in a red, on a red alert, as it were, in terms of the PPE standards that are being adopted, and you can also access those protocols online in terms of the standard precautions that are being recommended, as well as the visitor restrictions and entry restrictions. But just a couple of helpful resources there. I won't spend a lot of time on vaccination, although I know there's lots of vaccine questions, because I think you have the privilege of hearing from Dave Durheim and all the HNE team next week on this subject. So it'll be a dedicated session on vaccination. But just the key updates from the past week is obviously with the evolving outbreak in Greater Sydney, there's been advice from HNECC that people aged 18 and above in the Greater Sydney area should consider getting vaccinated with any available vaccine. As far as I'm aware, this advice has not been expanded to the Newcastle region, but I'll take that question on notice, assuming that's a question some of you have, particularly now HNE colleagues. The Pfizer vaccine remains preferred for people aged less than 60, but noting that there's huge issues with supply and access at the moment. So individuals are being encouraged to reassess the risks, which are, you know, relatively rare, versus the benefits, particularly in the context of you know, uncontrolled community transmission in outbreak areas. And there are a number of useful guides that have been developed on the Commonwealth website. There's quite a good easy read guide that's been developed. We can share those links to help patients kind of work through that decision and, you know, understand the changing climate in terms of the chance of catching COVID now versus the chance of developing a severe complication such as TTS. The other key change which transpired in the last few weeks is around the second dose of AstraZeneca. So previously recommended interval being 12 weeks for maximal effectiveness. However, it can be administered at 4 to 8 weeks to achieve that higher degree of protection in a more timely fashion. So again, this recommendation applies to outbreak affected areas. And also those key post-vaccination counselling points for your patients around watching for signs of TTS in the 4 to now 42 days post-vaccination. So that time frame has been extended, and those key red flags of, you know, persistent headaches, abdominal pain, leg swelling or pain, chest pain, or, you know, petechiae or unusual bleeding or bruising as all triggers to seek medical care, you know, to have a D-dimer or an FBE collected, and to get medical attention. So hopefully, my screen appears to be frozen, but hopefully it's talking about considerations for general practice. So, I mean, as I said, I'm not going to be sort of prescriptive about what you should be doing in your businesses, but I suppose just a few key points to be really thinking about carefully and how your practice manages these these considerations. So obviously patient triage and screening is a key one. So, you know, what are your systems? Your receptionists are absolutely gold, and they've been, you know, really at the front line in this. So, you know, what are your screening systems? What are your telehealth options? You know, making sure that the epidemiological criteria are really being strongly assessed, and also, you know, at the first sign of any symptoms, that there's appropriate sort of risk mitigation practices put in place. Another thing which has tended to come up as an issue in Greater Sydney and also in some of our local experiences around waiting room management. And I'd really encourage you to consider whether you need to have patients in a waiting room at all in the event that a COVID case, a person with COVID came into a waiting room setting. With, you know, this current climate of Delta, we'd probably end up deeming all people within that sort of closed space as close contacts. So there are significant implications, and, you know, when somebody has been put under 14 days of isolation, it can have impacts, you know, if they have further upcoming medical appointments or, you know, requirements for treatment and that sort of thing. So there is a big impact on patients if they become close contacts as a result of being exposed in a waiting room. I've mentioned briefly the PPE matrix, and as I said, the importance of eye protection and a mask. And then, of course, you know, we'd really love you to keep testing everybody. So have a very low threshold for testing. As I said, we have unlinked cases in the Central Coast, so and we have unexplained sewage detections. So we really do need to try and, well, so to speak, flush out any undetected cases in the community and really link up those chains and stop any ongoing chains of transmission. So please, if anybody has respiratory symptoms or any symptoms, really, please have a low threshold for testing for COVID. So sorry, I've run a bit over time, but I think that's most of the content that I've got.
Thanks, Kat. That was excellent. I'm just finding my camera. There we go. And I can see while you've been giving your presentation, Liz Grist has joined us. Welcome, Liz. And Lynne is back on camera. So what I'm going to do now is just go through a couple of the questions. I think some of them, Kat, you were actually able to answer in your presentation, but there's still a few that I think majority are probably going to come your way, but we'll see how we go. So the first question I think would be for yourself, Kat. Could you explain how the false negatives and positives in terms of pathology results, how that works, how often does it occur, and is there any additional information you have to add to that?
Yeah, look, I mean, there's further investigation being done into it. Anecdotally, we have heard a few case stories of, you know, cases having symptoms and testing negative, you know, 1 or 2 times before COVID is detected. We're still trying to unpack exactly what that represents, you know, whether they've had some other intercurrent illness or, you know, what's actually going on there. My understanding from some of the data from the first wave internationally is that, you know, there could, obviously somebody who's pre-symptomatic has a much lower chance of testing positive than someone who's acutely symptomatic. So from memory, I think at the point of symptom onset, it was still, you know, around a sensitivity of about 85%. So, you know, there's potentially false negatives there. And so certainly if somebody has ongoing symptoms, worsening symptoms, or increased epidemiological suspicion because they've been, you know, working in Sydney or whatever other exposure, or, you know, certainly they've had known contact with the case, we certainly recommend to repeat testing in 24 to 48 hours for those cases.
Brilliant. Thank you. Thank you. Moving on to the next question. There's a couple of questions I've noticed around PPE, but I think you sort of covered that in the later part of your presentation. It's specifically around sort of P2 N95 respirators and goggles potentially, you know, the timing and when should general practice be using them given the current situation?
Yeah, look, it's a good question. As I said, I won't profess to be an infection control expert, but I think this is an important issue, and potentially I'll, dob in our excellent infection control practitioners such as John Ferguson up in the Hunter. But the general consensus at the moment is that for most kind of standard consult length visits, a surgical mask and eye protection is sort of considered adequate. There would be some enhanced surveillance that would be put in around, a person that had been in that situation. But it's not automatically a close contact in that scenario. Really where the P2 N95 mask tends to be a lot more important is, I guess, when someone's having prolonged exposure, or where, the patient's very, very symptomatic and sort of coughing and spluttering all over the place. Or, where somebody's being exposed to quite a high viral load, such as working in a COVID ward where they're surrounded by COVID positive patients. So, generally in the general practice context, the advice still remains that, surgical mask and eye protection is probably going to be protective for, brief consults, but there's a whole bunch of risk assessment that happens within that, and, the adequacy of training and donning and doffing and that kind of thing. So in the event, heaven forbid it happens to your practice, the public health unit will be working quite closely with you around that risk assessment.
Thanks, Kat. And just on that, there's a further question around, is it recommended, or what are the thoughts around conducting vaccination clinics or swabbing clinics from a car park type situation, just following your recommendation about keeping people out of the waiting room?
Oh, Kim, sorry, I think my network is having issues. I think that was something about car park vaccinations. So I think there are some. I think there are some practices that have been doing this, and probably these practices should be seeking some guidance from the PHN and Commonwealth in the space. I mean, there's certainly no reason why it can't happen, but I guess one key thing that we want to emphasise is that people do need to have the requisite observation time after they've been vaccinated. So people can't just get their vaccine and drive straight off. But I guess there's a whole bunch of kind of quality controls and things that would need to be brought in that setting.
Great. Thank you, Kat. While I'm just going through a couple of the other questions, I thought it might be a good opportunity for perhaps Liz and Lynne, if there was anything that you wanted to update on or anything you wanted to add.
I'll let Lynne go first.
Thanks, Kimberley, and thanks for your presentation, Kat. Not really. I think it's, as we would recognise on the coast, the vaccination program has been quite fluid, but I think I'd like to acknowledge all the partners in the vaccination program and congratulate the amount of vaccination that is happening on the Central Coast. Whilst I know the public figures, I know there's been very strong connections and communications with key partners, and particularly working with key through the PHN, but also our GP network group, making sure around that we've got plans around our vulnerable groups, particularly our Aboriginal groups, our older people, etc. Noting that one of the groups that we want to start working with as early as next week is we're planning to go to retirement villages. It's different to the residential aged care, but actually taking teams into retirement villages to assist with those large cohorts of vaccinations. But no other updates, but happy to take any questions.
Thanks very much, Lynne, and over to you, Liz.
Well, I think that was a great summary by Kat. Thanks very much, and a really good overview. I think Kat's given you a lot of the data regarding Hunter New England and the challenges that we're facing at the moment. And I might have missed the beginning of it, but I think you might have mentioned that we've got 9 cases now, and two of those are new today. And we've got quite a number in close contacts in our hotel quarantine setting that we, have been, it's likely that they will become positive as well. Actually, I think we're moving 2 more out this afternoon because this virus seems to be a lot more contagious than what we've seen in the past. So I won't dwell on that unless anyone's got any questions. But for us, it's been the vaccine rollout that's been, you know, really problematic. Like you have on the coast, we had 11,000 doses of Pfizer taken away, and we've just been informed, of course, that now we're getting them back. So we've got to reinstate all of those appointments, which will be a real challenge. But it's great that we're getting it back, so we're not complaining too much. And as Kat mentioned about the AZ, I think the eligibility track is going to change, that it will include 18-year-olds up for our site as well. I'm not sure about the rest of the state. And also for pregnant women and people aged, children with chronic medical problems from 12 to 16. So I guess that's, unless people have got questions, that's all that I've got to sort of add to Kat's fabulous presentation. It was really great. Thank you.
Thank you very much. There's a couple of other questions that are coming through, and a number of them are around what the recommendation is for surveillance testing of health workers in these current locations.
Kat, do you want to answer that? Or I'm just actually working on our statement now, so I'll let you just have a go.
Oh, okay.
Yeah.
Sure. Look, currently, you know, there's obviously some requirements under the order for people in the specified LGAs, which is around surveillance testing for people that live in those areas and work outside those areas. So that's once every 72 hours. That hasn't yet been expanded. And also it doesn't apply in reverse, i.e. if somebody lives outside and works inside, that also doesn't apply to them. There's a separate requirement on health workers who work in Greater Sydney and live more than 50 k's outside, or the reverse. So there's that sort of bubble thing, which is sort of confusing everybody. And there's a requirement for a weekly test there. But certainly, you know, the issue of, you know, surveillance of healthcare workers in high risk settings is being actively discussed at a state level. So I'd be interested to hear what you have to say, Liz.
Oh, you're on mute, Liz.
Something that I've been working on this morning, so it's an interesting question because it sounds complicated, but basically we ask those who live in a red zone but work in an orange zone, so bearing in mind now our red zone has extended up to Muswellbrook, to attend for a weekly COVID-19 swab to ensure they remain negative. And after leaving the red zone, as long as they don't re-enter, they can stop the weekly surveillance after 14 days. But I need to simplify it for staff a little bit because it is a little bit complicated to get your head around, because it's only just happened, and they've got the stay-at-home orders, as you guys do on the Central Coast too. If you live in a red zone or visit a red zone since the 31st of July, but then go to an orange zone, which could be for us Scone or Stroud or further up. So it is a little bit complicated to get your head around, basically. But I think the important thing to remember is now we're all in a red zone. So it's when we leave to go to the orange zone that it becomes a problem. Does that make sense?
It makes as much sense as we can make out of such a confusing situation. Yeah. No, you explained it really well, Liz.
It is a confusing situation, and there's been a lot of people here who live on the coast who actually work in Sydney or live in Newcastle or vice versa. So it has been an area that we've been straddling with in the whole lockdown. For example, I work on the coast, but like Kat, we work on the coast but live in Newcastle. So when we go home, we have to live by the public health order of the coast. But we try and simplify it for staff, and most importantly, we look at it individually so that we can actually give the staff member an individual assessment and go through it that way. But yeah, it's a very fluid moment.
You stay home when you go home, don't you?
I stay home, don't we, Kat?
Yes. You're in the stay at home, so that's
what I'm
trying to explain to staff. which is really challenging because, you know, it's very hard to get, for some people to get their head around. And as you say, Lynn, every situation's a little slightly bit different.
I think you've made it as clear as you possibly can. It's not an easy one to explain. So thank you both. There's a couple of comments that have actually got people's details for either Lynne or Liz, and we can share that with you after the presentation, just reaching out to make contact, I believe, around vaccination. And I think that's probably it. I think we've covered most of the questions in there. There might be a couple that we haven't, and if it's okay with the presenters, we might just shoot those through after the webinar, and if there's anything that hasn't been covered, we can get back to people that way, if that's all right. All right, so I might actually bring Charles back in now because he works his magic to wind up the webinar, but thank you all kindly for joining us, and thank you for your time.
Thanks, Kim. And yes, thank you all for joining us, and a massive thank you to Kat, Lynne and Liz. You know, I know you're incredibly busy, and it's so valuable to have you online and to be able to provide this education across our whole region. As I mentioned at the start, the session is being recorded, so this recording will become available this afternoon on our website. So just head to the phn.com.au and click on the education tab. There will also be a quick evaluation survey that will pop up when the webinar ends. If you could just take a moment to fill that out, that would be really appreciated. All right, everyone, thanks again for joining us, and we hope you have a great afternoon.